Well, Dr. Sardi, you mentioned laparoscopy from sort of a diagnostic standpoint, potentially causing problems with the ports. But one of the questions out there is that there's been talk in various places about laparoscopic surgery with HIPEC as opposed to the open, the full open incision, performing the actual surgical procedure you're talking about, but laparoscopically, and then using the HIPEC. And I wonder if any of you have opinions on that in terms of proof, efficacy, etc.
I've seen the reports as well, and I think there are a lot of good roles for laparoscopy, but my personal feeling with this particular surgery is that I just don't think that you can get a good enough that you can get to all the far reaches of the places where, especially with like DPM or PMP, where it likes to go. Way behind the right liver, you can be operating. Stripping the peritoneum off of the right kidney all the way over to the right adrenal gland and the vena cava. To get there open is challenged. To get there laparoscopically, I couldn't do it. There probably are some laparoscopists who could. Similarly, I think to be able to run the whole small bowel, see every inch of the small bowel, and then there's actually some tactile sense that you have with open surgery that you don't have with the cameras and stuff. That I don't see a role for it yet in this. I don't, but. Again, I'm not a trained minimally invasive surgeon. I do laparoscopy as part, I've been trained in it, but not to that level, so I'll defer to Steve what your thoughts are.
Yeah, I mean, my partner's scheduled a few cases that way, which always end up getting opened if we're planning on doing the cytoreduction that way. But we use it often just as a decision-making tool at the beginning of surgery and more advanced patients to sort of get a sense of what things look like and be able to, and this is for more aggressive types of tumors, to look in, sort of get a sense whether things are going to be, whether we're going to get to a complete cytoreduction or not without making a big incision, so that if patients would benefit more from chemotherapy or if we're not going to help them, they can go on and not have to recover from a big incision before getting treated. So that's 95, 98% of the time we're using it for that.
So you're peeking in the window before you go in the door?
Yeah.
There are some things I think that you'll see with the laparoscope that are really going to give you pause and say, we're not going to get a complete cytoreduction. Let's not give this person a huge incision and delay their getting onto additional therapy.
Yeah, I think I do laparoscopic liver resections, laparoscopic splenectomy, laparoscopic adrenalectomy, laparoscopic colon resections, and I will not do this. I will not recommend this for. It's being proposed by some centers as a marketing tool, because most people end up being open anyway. But and I think the issue here is that when you have a lot of tumor, laparoscopy is not going to help you because you won't be able to see anything but tumor. We know that sometimes in open, it'll take you 3 hours to decide. I have cases. Most of my patients have a lot of tumor. It takes me 3 hours to decide whether I can do it. Now, 95% of the time, we can able to remove the tumor. 80% of the times complete cytoreduction. And 5% we say, listen, we cannot do this. But laparoscopy, even with people who have a small amount of disease, almost invariable, there's going to be tumor, Dr. Lambert said, behind the liver, around the IBC, in what we call the lesser sac, in the corner, it's almost always there. And I think it's important to remember you have one good shot. If you have to go second or third time, every time it's also going to be more difficult, but the chance of recurring is complicated, is a lot higher. So you have one good opportunity to have that well done. And that's true for any cancer. And actually, and I think other for diagnosis, as has been suggested, I will not recommend. We do laparoscopy to do of someone who has mesothelioma, who has unresectable or refused the cytoreduction to decrease the ascites. But that is a complete different. If you want have the best chance of survival, you need an open surgery. That's my feeling on that.